This is our last session, session 13, and we are looking at education before discharge. For session overview, preparation of the newborn and family towards discharge begins on the day of admission and continues throughout the period of hospitalization. The family should be made to understand that the child's stay in the hospital is temporary and he or she would be discharged as soon as possible as the condition returns to normal. Emphasis is placed on the fact that hospitalization process was to facilitate the newborn and family in their recovery. And this session introduced students to the education given to the family and the child involved, or the family, especially the mother, before discharge. Goals and objectives. At the end of the session, students will be able to evaluate knowledge level of parents and their educational needs, evaluate the needs of the infant prior and following discharge, identify screening measures for appropriate discharge, and provide information on infant care that are relevant to the infants being discharged from hospital, and also identify the home care needs and alarming signs to report. Key topics to be covered are as follows: discharge, discharge planning, types of discharge planning, criteria for discharge, how to discharge a patient, and educating parents on discharge. So Fraser and Cooper and Wong's Essential Pediatrics textbook address some of these topics. So discharge is a process, or discharge is the release of a patient from the hospital, clinic, or therapy program. And discharge planning, this is the process of preparing the client to leave one level of care to another within or outside the healthcare facility. We have types of discharge. This is done normally when the neonate is fully recovered. So when we talk about it, when the medical team, one type is discharged by a medical team. And this is when the patient has fully recovered and the medical team agrees that the child can go home and live normal lives. And the person responsible here, or in charge, or who can administer this release from the hospital, is a medical doctor in charge. And the nurses and other team members support. Another type is discharge against medical advice. This happens when the parents insist on taking the child or the newborn out of the hospital when the child has not fully recovered, and the need for admission is re-emphasized, elaborating the possible outcome of their decision. If the parents still insist and want to take the child home, they are allowed to write as a legal document before the release is administered. And criteria for discharge. Infant or newborn will be considered, or child will be considered fit for discharge when the symptoms or the condition he brought have fully subsided, and lab tests, if it's a disease condition, show that the infection has subsided significantly and he or she may go and continue in terms of taking the medication at home, or when the newborn especially now feeds very well or is also gaining weight and there is no need for any support for respiration. So the child breathes himself without any oxygen support. And now also when the medical also see that there are no complications and the mother has the adequate skill to continue the care at home, the mother is considered and spoken to, and then the child is discharged. So when this happens, before the child is discharged, there are processes involved. One type of discharge planning is immediate preparation, where maybe because of the nature of the condition they brought, will not require long stay. In that case, for example, when a mother comes to deliver and she has to go home after spontaneous vaginal delivery with a newborn and there is no problem, this will be considered under immediate preparation. The mother is educated on breastfeeding. She's also educated on rest because the education started at the antenatal clinic. So after delivery, all we do is to assess the newborn, make sure everything is well. The mother is given education on the importance of exclusive breastfeeding, rest, and a few tips. And then the mother goes home. But long-range preparation comes on board when, let's say, you have given birth to a preterm infant that has been at the neonatal intensive care unit. The education starts right from the neonatal intensive care unit period, where the mother is taught to express the milk because the baby cannot tolerate sucking. It's not strong enough to suckle on the breast. She's taught how to also feed the baby with cup and spoon. She's taught the process of cleaning her breast, her hands. And she's also taught some danger signs that tells her that a child is sick and all that. And she's taught how to care for the child at home, feeding with a cup and spoon in cases where maybe there is one problem or the other and there is an artificial creation on the stomach like gastrostomy just for feeding because maybe the child has taken some caustic soda and the throat is blocked. There is some degree of esophageal atresia. The mother is taught how to care, and if the child's age also allows it, the child is also brought on board and she's taught on some types of food that she can feed through these ostomy or opening for feeding, and how to care for the instruments involved. And we ensure that she can do this and take care of it appropriately before discharge. And even that, she'll be coming on and off at the OPD for review. So we make sure that she can manage this condition before she goes home. So this takes time before discharge. So that can be considered under long-term preparation or long-range preparation before discharge. So in educating parents before discharge, we educate the need for continuing the treatment at home. We also teach them when to come for their follow-up visits and explain how the drugs are taken. Today, the emphasis is on the measuring. Various medications come with measuring cups. So if it is 10 ml, it is better to tell the mother to use the cup and measure 10 ml than to take 2 teaspoonfuls. Because we all know from research that teaspoons vary depending on where the individual finds himself or herself. There can be a teaspoon that is 2.5 ml, there can be a teaspoon that is 5 ml, and there can be a teaspoon that is 7.5. And if the mother is not well educated, she may not know the variations involved. And so considering most of the women who come under our care, it is very, very important that we ensure that the measurement is done by the appropriate measuring cup to get it correct. If not, it may result in overdosing or underdosing of the child in terms of medication, and this can have serious side effects. Another is to remind the mother or the significant caregiver about review dates and stress on the importance of reporting when they see any danger signs, like when the child is not feeding well, the child has fever above 37.5, is vomiting, and is weak. Or the child has some convulsions, we teach them to report and not wait for the review date to be due. Also important key factor here is educating the mother on exclusive breastfeeding. That is a best practice because research has indicated that the breast milk is the best milk for the baby. And when the baby is exclusively breastfed for 6 months, other foods can be introduced. And most concern some mothers have in our part of the world, like Ghana, because of the high temperatures, is that the breast milk, the children who are exclusively breastfed do get thirsty. So it's important to let them know that the breast has the fore milk, which is mostly water, and will quench their thirst. So the child should be put to breast anytime it is hungry or thirsty. When this is done, and the mothers are also shown some pictures of children, or even some children around who have been exclusively breastfed, and they know the benefits of exclusive breastfeeding, they do practice it. In the past, Ghana chalked the success of around 78%, but today, currently, research has shown that the practice is going down. So there is a need to encourage mothers to exclusive breastfeed because it can be very stressful and demanding. Cord dressing. Mothers are taught to take their children to the nearest health centers for cord dressing. However, they are also taught how to clean the cord with methylated spirit after bathing the child, and they are made to buy some sterile dressing and methylated spirit from the pharmacy before discharge. So when we assess and the mother can do it, upon education, we encourage her to do it, but if not, we also let them go to the nearest clinic to have the cord dressing done. And in cases where they have it done, we also advise that every alternative, or even by the third day, they take the child or the newborn to the nearest clinic to see or have the cord evaluated. Personal hygiene is also another very important area that we educate. How to wear the diapers, it should be beneath the umbilicus and not above it, so that it doesn't get contaminated with fecal matter and urine. We also educate mothers that in cases where they use the diapers, they should change it when it's wet and clean their buttocks with water. Personal hygiene is one of the key areas that we advise. We teach mothers how to put on the diapers or napkins. It should be beneath the umbilicus, and also change it as soon as it gets contaminated, and wash the buttocks with water and soap, and also dry the area before they put on another. We also teach them the importance of cleaning the baby and letting them wear light clothing and expose the cord area for the cord to fall off and dry off. We also discourage some traditional practices of the use of broken bottles and the like, and other herbs that will facilitate the cord falling early, which also can be a source of infection. We also encourage them to wash their hands before and after caring for the baby. We also educate them on how to position the baby, how to put the baby to breast, and offer the breast so that the baby does not feed only on the nipple, such that there will be cracks and the nipples get sore. That will not also help the mother to exclusively breastfeed. So breastfeeding is taught, and the mothers are also supervised to do it under supervision, and we ensure that this is properly done before the mother is discharged. However, in cases where there is some exclusive breastfeed, spontaneous vaginal delivery, and because of patient numbers, sometimes we have some challenges in this area, but this should not be the case. We should ensure that the mother can adequately do all this, especially first-time mothers, before the mother and the newborn are discharged from hospital. Alarming signs to report. All these are taught to the mother. So before mother goes back home, she is informed about some of these alarming signs, and she's encouraged to report anytime there is reddening of the umbilical, distended abdomen, very high temperatures above 37.5, and there is also bluish discoloration of the extremities and mucous membrane. It connotes circulatory problem, which is central, so it's very serious, and the mother is encouraged to come to hospital. And anytime she sees yellowish discoloration of the sclera and it starts from the head, we tell them it's a sign of jaundice, and they have to also report. And then when the baby is not feeding well, it also connotes that the child is not well. the mother is supposed to report. And when there is difficulty in breathing, they see that the child makes efforts and is groaning, they have to report. And whenever they see any bleeding from any orifice, whether nasal, from the mouth, from the GIT, they have to report. And also refusal to feed several times in a row, or when there is excessive vomiting, any degree of weakness they observe, and signs of pain, and the child crying and cannot be consoled. A child's eyes also irritated and have some discharge. We tell mothers to observe for some of these danger signs and report for adequate care. Requirement for discharge. Before the patient is discharged, we have to make sure that all her drugs are made available and she's educated on them. And the admission and discharge book also has records that, and then the folder first and foremost is where we check to make sure that the patient has been discharged by the doctor, and then we let them give us a return demonstration on how to give the drugs at home after we have taught. And also admission and discharge books, we enter their names and their war state to let it reflect. And then also items such as any nasogastric tube or any connections, intravenous lines are all removed. And then any dirty linen on the patient's bed is also removed. And then also, if the patient cannot walk, we make sure that we put them in the wheelchair, and then relatives who must be ready around to support them come and accompany them, and we see them off. Discharging patients from the hospital, we need to also inform the family. We also ensure that the hospital bill is worked out and settled, and ensure that patients who are also on NHIS get the full benefits of the National Health Insurance Scheme, to promote it and get many more people to sign, and also help the parents to pack their belongings, and then we see them off and ensure that they don't leave any of their things. We make sure that those that need to be decontaminated are done when they leave. So this is a picture of a mother demonstrating how to breastfeed her baby at home. So this is all part of some of the things. And the parent is the most important. When we say parents, fathers are also inclusive, and any other significant other. In cultures where the grandmother or the mother-in-law is the one who has the final say, she is also brought on board, especially when it comes to the preterm, so that she will understand the importance of top and tailing and not giving elaborate baths, because this is the joy of some grandparents. So we have to let them understand the importance of keeping the newborn, especially the preterm, warm when they come home. So the family must be involved, and they need to understand why certain things are done, so that when they go back, they will make sure that this is done. And they must also be prepared with the necessary items to care for the newborn at home. And I talked about the need for getting methylated spirit and cotton to help them. And also, they must be given the support to come back whenever they need to. Educating parents on discharge. We have to educate them on the need for continuing treatment and not go and stop when the symptoms subside. And we also explain how the drugs should be taken. And I have said here that it must be done with a measuring cup and not teaspoon or tablespoon. That sometimes does not augur well for us. We have to remind the parents and relatives of review dates and educate the mother on exclusive breastfeeding. I have said this and I'm saying it again, and cord dressing. We've said all these already. So in conclusion, we have discussed the following: discharge planning, types of discharge planning, criteria for discharge, how to discharge a patient, and educating the mothers or family before discharge. So for our assignments, baby Z is a 2-week-old newborn who has been on the unit for 6 days or has been admitted to the baby's unit for 6 days. What criteria will inform her readiness for discharge? What will you consider as a midwife or as a pediatric nurse or as a general nurse that this baby now is ready for discharge? Discuss the education you give to the mother before discharge. Take time and practice and answer, and also have the discussion among yourselves. The textbooks that you can refer to have been cited here in the reference, and you can add up to the information on the slides. This is where we end our session.